Good morning and good afternoon, everybody. A very warm welcome here from Washington, D.C. to everybody participating in this very interesting session organized by our SecureNutrition colleagues. Thank you very much, first of all, to the team around Leslie and Aaron and Andrea and several other colleagues. We have a very interesting session this morning with five country presentations, basically around the topic of how social protection programs address nutrition behavior change. And that's really a very top-notch and interesting topic that these five countries have already worked on, but I'm sure others have also been engaged in this dialogue. So welcome, everybody. I know we have a lot of listeners also by audio. We have about 15, 20 people here in Washington. And, of course, we have several country offices connected. With that, I would actually, so the agenda for today is that we'll have five presentations from different countries: Mali, Tanzania, Mexico, Djibouti, and then Niger. And then we have an external expert with us, Manisha Tharaney, who's sitting here right beside us. And she's going to share some reflections on what she hears, what she sees, and from her own experience also. And after that, we'll have some time for open discussions. Hopefully, looking forward, how can we move this agenda forward? How can we collaborate possibly better? And what are we learning so far? What has worked and what is maybe difficult to do? And the closing would be around 10 a.m. Washington time. With that, actually, I would like to hand over to Mali, Mamadou Sakho, who is the project coordinator of the Emergency Safety Nets project in Bamako. Mamadou, are you there?
I'm here.
Excellent. So please go ahead and start the presentation, Mamadou.
Donc nous passons la parole à M. Sakho, coordinateur du projet du Mali, de bien vouloir commencer sa présentation.
Je fais cette présentation ouverte.
Sorry, we can't hear you.
Nutritional Sensitive Social Protection, Jigisemeri Program Mali. The context from this program, malnutrition in Mali. Yes, high level of malnutrition among under 5-year-old, underweight.
Did you receive the presentation? Do you see it over there?
No, we don't have it. We can't see it.
No, we can see it. Yeah.
On n'a pas une copie de la présentation, nous la voyons.
We can see it.
Non, si le truc on l'a affiché.
C'est bizarre ça. Qui a la dernière version?
C'est ça la dernière version.
Ça a été envoyé déjà. Il est renvoyé juste au cas où.
Parce que le câble ici, on ne peut pas le faire ici.
Mais je crois pas que c'était affiché par ici.
If you want to send the presentation quickly to Aaron,
Yeah.
he could upload it. Otherwise, we suggest you just start the presentation.
Okay, start and
Envoyer rapidement.
tu commences.
Another context for malnutrition in Mali, underweight 26%, stunting 38%, wasting 30%, anemia 82%. Height level of anemia among pregnant women, 51%. National strategy and intervention. Nutrition become a core element of the growth of poverty. Reduction strategy 2012 and 2017, and January 30, the Nutrition National Policy was adopted. Main object of policy improved nutrition and growth outcome after 5 years old. Axis our policy, growth monitoring, improved nutrition, reduce micronutrient deficiency, prevention on disease caused by malnutrition, school finding, improve family agriculture production, adapt social protection intervention to fight malnutrition, increase community involvement to fight malnutrition. The SME program is a conditional cash transfer program that provides GOST per quarter for poor family. Community level accompanying measure for all in the community. Information campaign. Pilot distribution of nutritional packet, fortified supplements for all children under 5 years old. For nutrition education to improve human capital, it's a C4D. You use a C4D method. Fortified supplement to increase micronutrition, nutrient intake.
We send you the presentation. I think you should have it by now.
We do.
To Aaron and Andrea.
Yes.
Okay, excellent.
Yes. Tu peux aller avancer.
Ahead. Non, c'est bon.
Devant encore. Ça, c'était le truc. Toi, tu n'as pas levé.
Okay.
J'ai pas la dernière version.
C'est pas la dernière version.
C'est ça la dernière version, je crois.
Ça correspond pas.
Oui, c'est pour moi qui est la dernière.
Sigrid?
We are listening.
Which slide are you on now?
I think there is a problem with the version, so just give us 10 seconds.
All right.
Secure sur la clé.
La clé ici.
Oui. Non, F. Ok, non.
C'est en bas. Il fait descendre.
Yes.
Would deliver nutrition education?
Say again, please.
slide 6, who delivers the nutrition education?
Okay. Go ahead. Speak. Just move on with the presentation, please.
Okay, we accompany measures that include nutrition and delivered by local and international NGOs. Different NGOs, one per committee, were hired by the project to do a census of the committee to identify households with children, do monitor attendance of session among cash beneficiary and no beneficiary, deliver nutritional package, and animate the information session. The content of the session and the planning were prepared at the committee led by Djibouti expert with the participation of government sector, health, education, social protection, government agency, ANAM, protection sanitary, CNSS, civil society, National Federation of Association of Community Health, UN partner, UNICEF, World Bank, WFP. What look manual were created for educator or for beneficiary? On the basis of 33 national policy, multi-sectoral plan for nutrition prepared in 2014, the committee has prepared the plan for the thematic section and the tools manual used to qualify national and regional actors from multiple agencies. The design of material were then based on pre-existing manual created either by the government or by the partner agency as UNICEF and WFP. NGO educators are identified by the NGOs and trained by the national and regional teams. The thematic for year here in the table. Okay. Nutrition education implementation, collaboration with government structure committee, civil society, is image from training in the town of Ségou and Koulikoro. Success and challenges. Success. To achieve the result of it's important to be aligned with nutrition strategy. National strategy C4D, cash transfer, committee participation. Provide continuous training of educators and national, regional, and local levels. Mobilize committee actors, intersectoral and interagency coordination. More than 75 of participation of beneficiary of cash transfer program. Challenge. Procurement of nutrition supplement require careful planning, still not delivered 6 and 8 month delay. Make sure people are aware of the timing of the session. Capitalization of achievement. Building capacity to influence of nutrition strategy. Yes, image for alimentation, children alimentations. We cook. Demonstration for cook. Here is animation, NGO staff and nutrition communication and JEMA. It's the first local region from Mali. It's end.
That's it.
Thank you very much.
Ça va pas être bien compris.
Excellent. Thank you very much, Mahmoud, to Mali. I think we'll continue right away with Tanzania. Amadeus Kamagenge is going to present to us the example from Tanzania. Amadeus, do we have you? Dar es Salaam.
Is it? Hello?
Yes.
Good morning. Can you hear us?
Yes, we can. Good morning, Amadeus. To introduce you, Amadeus is the Director of Community Support in the Tanzania Social Action Fund and responsible for the Tanzania Productive Social Safety Net Project. Go ahead, Amadeus.
Yeah, good morning, good afternoon. And can you see our presentation? We are trying to beam it.
Pardon? We cannot see the presentation, no.
We've sent also a copy to Aaron. Is it possible to?
Yes, if you could do that.
We have already sent to.
You've sent?
Andrea and.
Great, I see it.
Yeah.
You saw it?
We can. Yes. Go ahead, Amadeus.
Could you please go to a slide showing Tanzania Conditional Cash Transfer and Public Works Program?
Just a sec.
Okay. As the PowerPoint is being put on the screen, this is a project of 10 years, and it's reaching 1.1 million extreme poor households, about 6 million people. It is implemented in 2 phases of 5 years each. During the first 5 years, the main objective is to create a comprehensive, efficient, targeted social safety net to vulnerable section of the population of Tanzania. It is a nutrition-sensitive project promoting income and consumption, promoting care and health practices, and targeting nutritionally vulnerable population and accommodating the needs of women, so forth. Let's go to the next slide. Of course, we have the nutrition-specific indicators to be able to track that the program is indeed achieving all this. Regarding this question on how this nutrition-sensitive component fits in the rest of the project, firstly, let me say that for so many years, for more than 2 decades, the government partners have been struggling with the challenge of nutrition. You can see the numbers. For instance, stunting, when we had the first nationwide demographic health survey report, that is 1991, stunting was at 49.7. And about 20 years later, decline was very, very marginal. Stunting was still 42%. And this is the time when we are preparing to design this project. So the decision was to make sure that we make this project nutrition sensitive. And the studies show that the challenge of nutrition in Tanzania is not strongly linked to food security, because even in areas where there is plenty of food, still there is a challenge of nutrition. So you have to address other areas, particularly nutrition, targeted nutrition interventions. And of course, cash benefits for beneficiaries was purposely linked with nutrition education and changes in behavior. So we introduced community sessions, which are conducted just before delivering cash benefit. The idea is to make sure that message is delivered with a view to influencing and changing behavior. Next. We have tried to address 4 questions. One is related to who is delivering this nutrition education. Let me clarify that the way this program, the Productive Social Safety Net, is implemented in a decentralized governance structure. So implementation is taking place at the community level in the villages, but in the middle we have the local government authorities. So the program have entered into agreement with these local government authorities to make sure that they deliver the program. Nevertheless, when it comes to delivering nutrition education, these sectors take the lead, but delivery is again through this decentralized setting. So in terms of who delivers this nutrition education, we have extension staff who are based at the ward level. The ward level is just above the village level. But in the villages, we have village health workers. So who should deliver which topic depends on the specific topic, because at the ward level, you have a number of extension staff belonging to different sectors. But since we have the community sessions and the health facilities, in the health facilities, we have nurses who are employees who belong to the health sector. So they deliver this education. But at the community, in the community sessions, which take place in the communities just during the payment days, it could be health officers, community development officers, education officers, livestock officers, and so forth, depending on the topic which is being addressed. And again, we have these village health workers who are part of the health sector cadre. Let's go to the next slide, which is on partnership with local and international organizations. Indeed, there is partnership. You see, nutrition is multi-sectoral. So at the national level, it is the Prime Minister's office which is also responsible for coordination, which is chairing matters related to nutrition. But we have an organization called Tanzania Food and Nutrition Center. This serves as a secretariat. And then we have a number of ministries, around 10, that participate in matters related to nutrition. But we have agencies including UNICEF, DFID, Irish Aid, USAID, that support nutrition-related interventions, including development of and revision of documents. At the district level, again, being a decentralized setting, we have a director, of course, is responsible, but we have a district nutrition officer who is supported by development committee officer, but again, collaborating with district medical officer, district education officer, and other sectors also collaborate at that level. At the community level, again, we have these sectors working together. As I had indicated earlier on, when it's delivery of education, you have different sectors participating, or other players that are there at that level. Can we go to the other slide? And the other slide is on how were qualified educators identified, recruited, and trained. Identification of trainers, this is the role of the sectors. Here I'm referring to education, community development, water, agriculture, and so forth. They identify these educators, and then they recruit these educators. But given the decentralized setting, these educators are employees of local government authorities. When I'm saying local government authorities, I'm referring to these councils, town councils, municipal councils, city councils. And then when it comes to their training, for long-term training, this is organized through sectors. But for short-term training, this is conducted or organized by respective local government authorities or local NGOs supported by international organizations like UNICEF, DFID, USAID, and so forth. And these agencies like USAID, they provide support through other NGOs like Africa and so forth to make sure that short-term training is provided. Let's go to another slide. this is about the process of designing these materials. Preparation of designing and development of these materials is always done at the central level by the Tanzania Food and Nutrition Center take the lead. And sometimes this could be through commissioning studies or research or consultancies, but sectors participate in clearing these or reviewing these documents and making sure that they comply with their sectors of the respective ministries. And then there are some materials which are specifically developed by ministries like Ministries of Water, Health, Agriculture, and so forth, depending on the topic. But for materials used under this program, they've been put together after looking into the requirements, meaning that these were pre-existing manuals, handbooks, flip charts, which have been reviewed and then say, for these specific beneficiaries, these are the materials. And just to before going to the last slide, to give you the impact, currently we have about 1.6 beneficiaries who are supposed to comply. 1.6 million beneficiaries who are supposed to comply with core responsibilities. So you can just see the impact, because when before payment, they either go to the community session, and even without the payment, they have to visit the health facility where education is provided before undertaking other activities. These photos show just some of the sessions, the community sessions, which are administered or delivered just before paying cash benefits. In a summary, this is what we are doing in Tanzania on changing behavior through this community education. Thank you very much for your kind attention.
Thank you very much, Amadem. This was very interesting. Thanks also for sharing the photos. With that, we're going to Mexico, and there we have Daniel Aceves Villagran. Daniel?
Andrea, good morning.
Excellent. Buenos días, Daniel. Adelante.
Go ahead. Okay. Very much. First of all, I would like to thank World Bank Generosity for allowing us to learn and to share some of the experiences, because Prospera program, that is a social inclusion program, that it was called before Oportunidades, wasn't able to be understood without some international organizations such as the World Bank. I have two very important colleagues with me, Mrs. Licenciada Alejandra Villa de la Vega and Joaquín Carrasco. Within the aspects we would like to share with you is that here in Mexico we have a social protection in terms of health that is complied by the Seguro Popular or Popular Secure Siglo XXI from 0 to 59 months old, a protection fund against disaster events, and in a core part is the health component of Prospera, that is a social program that has one of the objectives is to develop nutrition, to have the promotion actions for health, a comprehensive strategy towards nutrition, infant development, and also some culture and self-care workshops. This program has its purpose of to disrupt this intergenerational cycle of poverty by increasing capacities in education, health, food, and also to be a bond in all these social characters. In terms of health, by providing a basic package to promote a better nutrition and also to promote a self-care education of health. In Mexico, we have 6.2 million families being attended by the healthcare system that represent 6 million people. And in control, we have 1.5 million of children under 5-year-old and 300,000 pregnant women. So we're trying to go across all the different levels with these strategies, integrating these nutrition strategies, child development and early stimulation, also an indigenous communication plan, health self-care workshops, and health. One of the important circumstances is that based on the current studies, 1 out of 5 women that are pregnant has anemia. 3 out of 4 above 19-year-old are overweight or had obesity. And 1 out of 5 children in rural areas have this exclusive breastfeeding. 1 out of 7 in urban areas has breastfeeding only. And we have 21.4% of delay in development, and more than 30% of the children are overweight or has obesity. So the institutional response to all of these problems is towards going to the different levels, all the different strategies, such as the comprehensive strategy for nutrition that has the main purpose to get new
excuse me, un momento, por favor, Daniel. Just a second. We have somebody in the line with a child that we can hear. Could you please all mute your microphones, please, so that we don't hear anybody else but the Mexican presentation, please? Okay. Do we still hear the child?
It's not here in Mexico.
Bueno. So let's continue. Thank you very much. Adelante, Daniel.
Thank you, Andrea. So, facing that scenario that we have presented to all of you, this comprehensive strategy towards nutrition has all these components that are new: food supplements, some equipment of somatometry at the first level units, and a training program. The SCN's objective is that during the first 1,000 days of life that are constituted from 370 during the pregnancy period, 730 of the first 2 years, and especially looking towards a positive impact for the future of children. Food supplements that we are showing in this slide are 4 of them, and they're related to Vita Niño, Nutrisana, Nutrivida, and some lactose beverage. So from 6 months old to 59 months, and also for pregnant women and for women that are breastfeeding, can go along with this process. We have carried out some scientific studies on the impact of these supplements, and the results have been quite exciting and positive. We can see a reduction of 41% of anemia in rural areas, more than 50% in urban areas, and pregnant women as well as women that are breastfeeding can increase hemoglobin in a more than 2%. In relation to, regarding the self-care workshops, this is a very powerful tool because we can have more than 1.7 million sessions per year discussing different important topics that are part of the concern of the different health items of Prospera community. We're also implementing for the first time a link of Prospera at your home that is related to follow-up at home through the different figures of women that are pregnant or in the breastfeeding process, through different health assistants and some other health professionals as a volunteer, that would follow up all these supplements to the communication plan for the indigenous people and also to a comprehensive strategy towards nutrition. This indigenous communication plan has the most important topics. Currently, in Mexico, we have more than 68 languages, indigenous languages, with more than 363 variables in dialects. And we have more than 11 million people that talk indigenous languages. The child development and early stimulation strategy has created more than 1 million scannings for the early detection and the evaluation of the development in a traffic light or using these colors that is going to provide some results where 12% has problems in development, especially in language. This is why we have created some regional development centers for children. We have 10 centers currently, and this year we'll go up to 30 centers at national level, and they are going to coordinate the strategy. They will provide prompt attention, a prompt care, and they will have the reference and counter-reference of those children that have development problems. We have promoted the figure of a health assistant, who are people from the community that are going to be appointed in the session, and they have just a very symbolic income, and they will help us to give the attention to those communities that are the farthest from the health units. We have designed some materials for the social protection. We have all these manuals for all these promoters, for health assistants, for members, for volunteers, all a series of flip charts in terms of exclusive breastfeeding, for child nutrition, and they have been distributed in more than 16,000 health units at the first level, along with comics, some balls that could not be punctured, some ropes, DVDs, among other materials. Finally, we are trying to locate this union among the different levels, where the core attention are children and women, and it could not be understood by aligning all the different levels or going across levels, where we should keep the budgets from the government to create the programs that are gonna attend some planning programs for the family members and all the different concepts related to this topic. Thank you very much.
Thank you very much to Mexico. Very large program and very comprehensive activities. Thanks for presenting that. Now, we have Djibouti next. We have two presenters from Djibouti. Stephanie Brodman, who's a senior economist at the World Bank in Djibouti. And responsible for the Djibouti Social Safety Net Project. And we have Suleika Mohammed. She's the coordinator of the nutrition component of the project.
Thank you very much, Andrea. This is Stephanie from Vienna, and the Djibouti Social Safety Net Project is really an integrated intervention with two main objectives. The first is to support the improvement of nutrition practices among households with pregnant lactating women and children from 0 to 2 years of age, so the first 1,000 days in a person's life. And the second is to support the provision of short-term employment opportunities, so labor-intensive works and services. And those two parts go integrally together. Only the beneficiaries of the nutrition sessions can become beneficiaries of the workfare program as well. And compared to the other programs that we've just seen, the targets in Djibouti are rather modest. But what I think is unique about this program is that it really is nutrition sensitive in a sense that it focuses very much on the caregiver in the household. So it doesn't just target nutritionally vulnerable populations. It makes the access to income conditional on the caregiver attending the nutrition sessions, as I just said. But it's also really the caregiver herself who is targeted and who has the first choice whether she wants to work or not, or whether she wants to delegate to a household member. The nutrition, the workfare activities are nutrition sensitive as far as possible, and examples include soil conservation, water retention, and urban gardening. The workfare accommodates women's needs, that is rather light in terms of labor and services. It has extended breastfeeding breaks, and overall working hours are rather short. And my colleague Suleika will go more into the details of the nutrition education itself. Just to say also that we are focusing on collecting nutrition indicators, for example, the share of participants that exclusively breastfeed, the number or the share that have 3 or 4 prenatal consultations, diet diversity among children and women. And we do this mainly within rigorous impact evaluation. And the objective of the impact evaluation is to assess the benefit of linking a workfare program with a nutrition intervention. And our results at midline, so in the short term, have shown that those households who not only get the nutrition education but also access the extra income through the workfare, their children are more likely to be eating foods rich in vitamins. The youngest child is more likely to have a diversified diet. And obviously these women have a much higher, or they are activated into the labor force. They have higher employment rates and labor force participation in the short term, as this is a short-term workfare program. And it does not substitute their labor away from other wage employment. And then some evidence that we have seen by really participating in the workfare, these women are quite motivated. They perceive themselves as more entrepreneurial, that have received or have now more ideas what they could actually do as a livelihood opportunity. So we see a number of small businesses opened by these women. So now I've talked enough about the workfare, and I will hand over to Suleika, who is the coordinator of the nutrition program at the Djibouti Social Development Agency, ADDS. Suleika?
Thank you very much, Stephanie. Can you all hear me?
Yes, we can.
Brilliant. Okay. So our presentation thank you so much, Stephanie, for a very good introduction of our presentation. We're now going to go into the operational and the technical details of our program. So our target groups are pregnant women as well as women who have children up to the age of 2. In terms of the nutrition educations that they receive. We have sessions for the pregnant women as well as sessions for the women with the children. So they each have their own specific sessions and they get their own specific nutrition and health-related messages. And what it also helps us to do is also to monitor the growth of the child, and the facilitators that we've got in our sessions do also the MUAC, the mid-upper arm circumference. All of that is, put into a register, and that is, enables us to follow the health of the child and as well as the nutrition status of the child. If the child is found to be malnourished, the facilitator does the referral, and we're able to detect malnutrition at an early stage. We have our group discussions, which is done by our mère conseillère, and within within those discussions, we try to develop a theme for each month, so that when our beneficiaries come, they have something to look forward to. It might be a follow-up on the previous theme of last month, as well as developing a new one. We distribute micronutrients as well as and supplements during the lean season as well. Next, please. Thank you. In this picture, you can see one of our mère conseillères who's passing on the nutrition education to them. She has what we call a boîte à images, or an image book, and that book has got for different themes. And what we try to do is, depending on the circumstances of the session on that day, the mère conseillère uses the image book as a support to really give this message that she's trying to convey on that day. So our mère conseillères are local, active, older women. They mobilize the women to come to our sessions, and based on the circumstances, have those discussions, and also are in charge of doing the cooking sessions as well. In terms of how they were chosen, when the project is being launched, we go to a local area where we're going to have the intervention, and then we discuss with local elders, sort of discuss the project to them, and within those discussions, they try to suggest women who would be good for this role, and that's how we work with them. And also, in terms of the work that they do, these women are volunteers, so they don't get paid for the work that they do to mobilize, to give out the message. So we have a partnership with the WFP, the World Food Programme, and they get rations each trimester. So it's also to keep them motivating to carry on this fantastic work that they're doing. And I think I would even say that they're the pillars of our social safety net program, especially when it comes to nutrition. So we discussed the mère conseillère who do the nutrition education and the cooking sessions. We also have facilitators who are local young women as well, who are educated, and they are in charge of the overall activity of the session of that day. They work with mère conseillère, so each site would have one facilitator who would do the weight. So you can see the child having his weight taken. She would also do the height measurement, and that is done every 3 months. And we have our monitor chart, a growth chart, to monitor how the child is growing. So they're in charge of anything, sort of written, as well as writing the referrals. Since they're educated, they're sort of able to do that. And even within those sessions, they have the mère conseillère who are supporting them, not only in the nutrition education as well as the cooking sessions, but also to send each woman to have, for the child to have his or her height and weight taken. So these women are, they're not volunteers, so they are actually paid through the program and are trained by us, the Djibouti Agency for Social Development. And they also get, as well as them and the mère conseillère, they get refresher training every 6 months from us as well. Next, please. Thank you. In terms of the partnership that we have with local and international organizations, in order to implement the social safety net program in Djibouti, we have 3 different approaches. So we use local NGOs who are very important in terms of not just the safety net program, but also have worked in other programs, so who knows how projects on a large scale work. We work with community-based associations, and what's good about that is that everyone in, whether it's mère conseillère, whether it's facilitatrice, they're very much based in the community, and it really allows us to have this community cohesion, which is very good when we have a community program like the social safety net. And the last approach we use is also the agency approach, and that is that we ourselves hire the facilitators as well as the regional supervisors. However, in the long term, we're thinking of focusing mainly on the community-based associations to really help sustain the program in the long term. We believe it's the way forward because they have a big presence in local communities, and there are so many associations to work with as well. So it gives us that flexibility and freedom to work with various associations. So that would be the long-term view. With regards to partnership with international organizations, we have the World Food Programme who provide the rations for our mère conseillère as well as for our cooking sessions, and also FAO, who we work with to have the urban gardens through our work fair components. And also for us as well, we have what we call nutrition clusters, and these are monthly meetings with various stakeholders. So in there we would have UNICEF, WFP, ourselves. It's chaired by the Ministry of Health, as well as Action contre la faim, and it enables us to, because we're all actors working within the nutrition sector in Djibouti, it gives us the chance to exchange ideas during those meetings and also how to coordinate our effort to have a big impact when it comes to nutrition in Djibouti. We have developed many tools and manuals for our session. The first one being the session guide, and in the session guide there is guidance on the nutrition education. So what questions that maybe a mère conseillère should ask beneficiaries to stimulate a discussion. There's also how the facilitatrice, when she does the weight and height measurements as well as the MOAC, the sort of feedback that she should give to the mother so that they can have this interaction as well, and the mother knows exactly what's happening in regards to the nutrition and the health status of the child. And in the nutrition guide, we also have recipes and ideas for the cooking sessions. We have our manual as well as the protocol, which is, has been developed by the Ministry of Health. The boîte à images, which has various themes. Although we try to focus on the circumstances of the session on that day. For instance, if we're in that, right now we're in the cold season, so we would have higher rates of malaria. So we would really put the focus on that, how we can try to minimize the effects of malaria in the community. So the boîte à images is a support that the mère conseillère use for the nutrition education, but we really focus on what is going on in the session on that day. We have a growth curve, which has been endorsed and approved by the WHO. We have our registration books to enable us to follow the nutrition status of the child, and each child has got its own page, so we're able to really see developments or to monitor the weight, the height of the child, as well as the health status. So we have sections for vaccinations as well, which is very important. So it enables us to remind the mother when the vaccination is due. We have a checklist which is available in all of our sites, and when we go and do supervisions, we write in the checklist and really try to give feedback to the facilitatrice to improve the session next time. We work with our mère conseillère to develop children's themes, because they're active older women, so they would know traditional songs that would calm children, and it's very important to have a calm session so that the mère conseillère can give a really constructive nutrition education. So we have one of our mère conseillères who's always good with songs for the children, and it's quite good, it's very pleasant. The recipes for the cooking demonstration also can be found in the session guide, but we've also got one which we prepared ourselves, and a guidance on the use of supplements, and that's very important because there are sometimes delay in the procurement of these supplements. So it's very important that facilitatrices are aware of how and when the supplements should be used, and we have the guides available in all our sites. And I think that's it. So thank you very much.
Thank you very much. Very interesting to hear from Djibouti, including some results already from evaluations. That's excellent. Now, our last presenter this morning is Carlo Del Nino, our senior economist from Social Protection and Labor GP here in Washington. Carlo, go ahead, on Niger, of course.
Thank you very much. Thanks for giving us the opportunity to participate to this very interesting panel. First of all, I'm missing Patrick, who works with us very actively on this project. He's in Côte d'Ivoire at the moment. So the project, a couple of words about the project. This project is, this project has been, the objective of this project is to support an effective safety net system to increase access of poor and food insecure to cash transfer and cash for work programs. So the main components are a system building component, and then there is a cash for work component, and then the component which we're going to be focusing on this morning is the cash transfer component with accompanying measures. This is an unconditional cash transfers that covers currently, there's been covering about 80,000 households. The nutrition sensitive component is focusing on these recipients of cash transfers on the nutritionally vulnerable population, and promotes both income consumption through cash transfers and caring and health practices. Now, this cash transfer component is the objective is to support poor and food insecure households. The beneficiaries participate in this program through a cycle of 24 months. During this time, they receive about 10,000 francs CFA per month, which is about $20. This is a monthly transfers. Every month they receive this money. The targeting is carried out through geographical targeting, identifying the poorest communes with the highest level of chronic poverty, and then proximity tests and community validation. The recipients of these transfers are the women, and we do not differentiate between polygamous and households, single households. There are two types of accompanying measures which are carried out with these programs. One is focuses on income-generating activities and productive activities. These are done through organizing savings groups and women groups, and this is something which we're going to be focusing more and more in the future. But one which we're focusing on right now is the behavioral component, the volet comportemental. Now, here the objective is to achieve some kind of behavioral changing and get the households to invest in human capital of the young children. So encourage adoption of positive parenting practices and participation of this behavioral component is a soft condition. So it's something which is measured, but it's not something which will preclude households to receive their transfers if they're not. But anyhow, the participation rate is above 90%, so there's not something a big concern about. People do not participate into these activities. Now, this component is delivered through a combination of activities. There are mostly this is organized through NGOs and with the oversight of the project regional offices. We have, there are 3 levels of activities. There are monthly community assemblies, which are delivered by the NGO. So everybody in the village participate, beneficiaries and non-beneficiaries participate to these activities. Then we have monthly meetings, which are delivered by community educators, and these are delivered to the beneficiaries. And then there are monthly household visits by these community educators. These community educators, we call them relais communautaires. There are about 3 activities that take place every month for each of the beneficiaries. And all these activities, they are carried out for a period of 18 months. So all the beneficiaries stay in the program for 24 months, and within the first 6 months of the project, these accompanying measures and training activities take place. So it's there is kind of a belief that the combination of cash and accompanying measures will achieve better results than cash alone or training activities alone. Now, there is a standardized technical guide which is being elaborated and is being implemented in a very systematic fashions. And I'll say a couple of things later about this one. And is delivered through NGOs through a very high intensive quality control. There is one community health educator every 25 households. We call them les relais communautaires, which are one field worker for the NGO every 300, 400 beneficiaries. And there is one quality controller for 8 field workers, which are carried out by the NGO. And then there is a supervisor at regional levels which does the supervision of these activities to basically make sure that all these NGOs do the job correctly. Now, in terms of tools which are created, there is a lot of emphasis on child development, early childhood development, nutrition, cognitive and emotional stimulation. And this is something which is very peculiar to the project because, one thing that we found out when we started working in Niger is that early childhood stimulation was very, very low. That there is this belief that women did not speak to the children before the children was able to speak themselves. So that caused a huge level of retardation of the child development. Now, there was, when we started working in Niger, there was a package which was developed by UNICEF, which was the Essential Family Practice Package, which was 8 levels of caring practices, which was developed by UNICEF. So we kind of tried to merge the 2 approaches. But the content was expanded, strengthened some thematic aspects of nutrition, and the really cool, one of the really cool things was these psychological stimulations. Now, the technical guide established the different levels, the different levels of implementations, and the tools were piloted and then were developed and use systematic communications, posters, image, lots of big posters and things. Now, in order to give you a little bit of an idea of the content of this behavioral component, we have a focus on nutrition, which is exclusive breastfeeding, complementary feeding, malnutrition, vitamin supplement, and deworming and iron absorptions. And one of the things interesting which is happening is that not only there is a focus on early exclusive breastfeeding from the beneficiaries' households, but also the other households, especially when there are in the small villages where there are few children which are born, I mean, everybody kind of like focuses on that, and there is a lot of participation on that. On health, there is protection of children against diseases, promotion of vaccination, children care after the first signs of diseases, and a lot of emphasis on hygiene and hand washing and things like that. That's where also the combination with the cash for the cost of the soap and things like that. There are a lot of talks about Niger in the news because they're having the elections this weekend, and this is one of the poorest countries in the world with the lowest development indicators in the world. And the cycle stimulation, this is, as I mentioned before, this is very cool part of the project. There has been a baseline surveys, and there are a lot of tools to test the cognitive development of the children and with the little toys and things like that. And then there is going to be something which we just starting is the family planning, birth spacing, and conflict management. Now, successes and challenges. The soft conditions are really well appreciated. There's very high level of participation. As I say it's between 92, 95%. And there is a lot of participations from non-beneficiaries, and they also facilitate a lot of very strong social dynamics. The focus on equality is essential. There is a lot of oversight, and there is a lot of this big cascade of people which are involved and this oversight. But one of the key elements is this, which I mentioned before, this relais communautaire. They work in these villages, and they receive the same level of transfers as the beneficiaries. So as the beneficiaries get about $20 a month, the relais communautaires also get about $20 a month, and they participate to this project. The quality of this work suggests that the beneficiaries know the messages, and I've participated in some meetings where they were quizzed about knowing what they were supposed to be doing. In terms of quantitative results, this is something that Patrick is working on that, and more to come in the following weeks and months about the actual impact on the nutritional outcome indicators. Thank you.
Thank you very much, Carlo. Very interesting and different aspects altogether. Now, we've heard from 5 different countries, 5 very different models and approaches, a very rich, I think, experience that is here. We are now very happy to have Manisha Tharaney, who is a Senior Technical Advisor for Nutrition at the Family Health International, which is an NGO, international NGO with headquarters here in Washington. And she is actually the manager of a project called Alive and Thrive. So with that, we would like to hear some reflections from Manisha on what we've heard, maybe on the way forward, and based on your experience. Thank you.
Yeah, please, close to you.
Okay. So thank you, everyone. I'd like to start by actually congratulating all our country teams. The very fact that you have started addressing nutrition behavior change in the social protection programs is a big accomplishment. So I congratulate you on the first step. Like Andreas said, I work on a project called Alive and Thrive, which is sort of dedicated to saving lives and preventing undernutrition using behavior change practices. In the first 5 years of the program, we showed that by using innovative approaches, we can have a big impact on different nutrition behaviors. And I'm here today to sort of share our experiences, some of the best practices that we've learned over the last 5 years, and some lessons learned in terms of the challenges that we encountered in changing behaviors. So sometimes there's a lot of confusion about nutrition education and behavior change. And I'd just like to kind of highlight that a behavior is sort of an action that's observable, is specific to a time, place, and it's measurable. So we definitely want to improve nutrition education. We want to change the way people do things, but we really need to focus in on behaviors. And And how do we do that? So based on Alive and Thrive's experiences, the success of a behavior change intervention depends on 4 key components. And the first one is the choice of a behavior. So I guess the temptation for all of us as practitioners or working in nutrition or even in social protection program is to want to change a lot of behaviors too soon. So our experience has shown that it's better to start with 1 or 2 very specific behaviors that would have a high impact and will be feasible and doable for families. So while choosing a behavior, so how do you choose a behavior? And again, here, what we do is often we start by doing some secondary analysis. Most countries already have the data. They exist in demographic and health surveys or multiple indicator cluster surveys. And then we also accompany the secondary analysis by doing what we call field trials, like trials of improved practices, which kind of entails going out to the community and speaking to mothers and other caretakers of what's really feasible and doable. So I guess the first step is really the choice of the behavior. Choose a behavior that can have a high impact and is feasible for families to do. I'd like to provide an example from our work in Ethiopia, where we are trying to also work with the social protection program there, but our behavior change strategy in Ethiopia is sort of focusing. One of the key behaviors that we're focusing on is improving the dietary diversity of children 6 to 23 months. And we arrived at this behavior by doing some secondary analysis. So when we looked at the demographic and health surveys in Ethiopia, we found that this indicator hasn't improved in the last 15 to 20 years, and only 4% of children eat foods from 4 different groups, and we know that this can have a big impact on stunting. So we also did some additional analysis to look at what are the determinants, or why aren't children eating more food groups, and we found that in addition to the usual determinants like wealth and maternal education, religion. So religion played a big role. So, for example, in Ethiopia, a large proportion of the population belongs to the Orthodox Christian community, and they have 200 days of fasting, like where it's a vegan fast. And so even though children are exempt from the fast, mothers and caregivers don't feed the child animal source foods on those days because they don't buy it. And even if milk and eggs are available at home, they don't to feed children those foods. So we decided that that would be our priority behavior. So the second important component of the behavior change strategy is to develop persuasive messages. And I think, Carlo, you mentioned that what we see in a lot of behavior change programs is a big improvement in knowledge, but knowledge is not necessarily a sufficient condition to improve behavior change. So based on Alive and Thrive's experience, we've realized that persuasive messages are those in which the mother or the caretaker would believe that the behavior would give her, is something that she aspires for her child, for her family. And the mother should also believe that this is a social norm. So she shouldn't feel like she's the only one practicing that behavior, but sort of promoted as like this is a norm and this is for everyone to do. So how do we do that? So the third component is that it's critical to focus the behavior by providing it in multiple ways and by using multiple platforms. So not only should we vary the way the behavior, the message is promoted, but we should also promote the same message to different members of the community. So it's really critical not just to influence the mother, but also who are the key decision makers in her environment. So fathers, grandmothers, all of them need to be part of the behavior change strategy if we want to really influence the environment. So, for example, when it came to dietary diversity, we definitely worked with mothers and promoted messages through the frontline health workers about adding eggs and milk because we realized that that's more easily available in the household than meat. in the child's porridge once the child turns 6 months. So we worked, we are working with the Health Extension Program in Ethiopia to counsel mothers on age-appropriate counseling. But in addition to that, we've recognized that it's important to work with fathers to make sure that they save some money to buy eggs and milk, because they're the ones who actually control the resources, and they can play a very critical role in promoting, in buying or purchasing products for the mothers. If the households own livestock, it's very easy to tailor a message to them and say, save at least 1 cup of milk for your child every day. If the household has poultry, again, it's easy to say, can you save an egg for your child? We've also worked with agriculture extension agents to promote to promote vegetable gardens at the household level. So it's critical to tailor messages around the same intervention for different target audiences if we really want to change a behavior. Another very important component of our behavior change experience is that intensity matters. So if you really want to see a behavior, it's very important that a mother, a caregiver, or whoever your target audience is, hears the message for a number of times and in a number of ways, because hearing a message once may encourage the individual to practice that behavior because of perceived benefits, but if they hear it multiple times, then it's much more likely that that's tailored to their context, and it increases the likelihood that the person would practice the behavior. And again, frequency of message also provides the perception that this behavior is the social norm and it exists in the community and it should be promoted. So intensity really matters. One other thing that we've done in the Alive and Thrive program, and that might be useful and relevant to our social protection colleagues, is the use of mass media. So in addition to interpersonal communication and group messaging, we found that mass media can be an effective way to synergize behaviors and promote social norms around a relevant behavior. And here again, intensity matters. So you don't want a radio program or a TV spot that's shown once every 2 or 3 months. The more you bombard the community with a radio spot or a TV message, and if you promote it through billboards and just many different ways, a magazine format, then the likelihood of a behavior changing is very essential. And finally, the fourth most important component is to really get feedback and to monitor what you're doing, because you could have a great program, but it's really essential to know whether the audience is being reached and how the audience is changing their response in the program that you're delivering. Another important thing to measure is exposure to messages. So you might have a great program, but if it's not reaching the target audience, it's not very useful. So it's really critical to measure exposure and whether it's reaching the right audience. And finally, also, it's very important to measure whether the messages are being understood in the way they're meant to be understood. So, yeah. So those are the 4 key components that we just need to think through while designing a behavior change program. But it sounds like everyone's on the right track, and they're doing pretty well with the design of some of these interventions.
Thank you very much, Manisha. Very interesting, and I think actually additional points to think about. With that, we have about 30 minutes for a discussion. I would like to start the discussion because we've heard a lot from the social protection teams this morning, and I know there's a lot of health nutrition colleagues here, and I think we'd be very interested to get some thoughts, some reflections on what you've heard in the presentations from the countries this morning. What do you take away from that? What did you have an aha moment where you thought, oh, really? Hopefully positive, maybe thinking, not sure that is really working. So we'd like to open the discussion that way. Any reactions from, yes, explicitly the nutrition and health colleagues at this point in response to the presentations? And of course, people in the field and people connected by audio are also welcome. You just need to start speaking, then we see you and hear you. Okay, we have one person here in Washington. Yes. I think you need to come close to a mic. Yes.
And then turn it on.
She will need to. Yes.
Hi, I'm Ashley Augustin with Spring. And a question I have for any of the presenters, but particularly I think the social protection folks, would be around household budgeting as a nutrition-sensitive exercise and kind of skills building around that, budgeting for better nutrition and health and care kind of input purchasing and accessing services and that sort of thing, and particularly sort of gendered aspects of that as well. Thank you.
And may I ask, is that something that you have found helpful and useful? That's probably where your question is coming from.
We're sort of testing out at Spring different approaches to incorporating these kinds of skill building things, but we're very much in the testing phase, and so really interested in other people's experience around that.
Very good, very good. Are there any other questions, reflections, thoughts? Yes, please.
Just a question, I think it was for Carlo, about the transfers in Niger, or in general. I wasn't clear in some of the presentations whether the transfer was cash or food, but when it was cash, how, given that people aren't coming necessarily to retrieve their food basket, how did you use them as a captive audience to like corral a session or get people's attention if they weren't necessarily coming to a central point, if they weren't coming to a central point?
Any questions from the field? Are you still out there? Okay. All right. Then we'll start with, does anybody have some insights on household budgeting? Has anybody in any of the countries worked with that?
Yeah, I'll take the Niger question and say a couple of things.
All right. What on your...
I'm sorry. Yeah, I'll take the Niger question and say a couple of things about, and then I make ask other people to say a couple more things about the budgeting. The cash transfers are made on a monthly basis in Niger, and there are just only cash transfers. There are no other transfers which are made, and the delivery of the education package is done not in parallel with the cash transfers, and there are no other incentives for the participation. But as I was trying to say before, there is a dynamic which has been kind of established with a very strong tools and participation. So there is a very there's very interesting dynamics which take place as people like to participate and more people participate. And I thought that, one of the important things that Manisha was saying is that it's not only important to train the beneficiaries, but I mean, if you want to have reached your message, you need to also reach other people. And the participation of the grandmothers, the neighbors, and everybody, and the man standing behind. I think this is a very important component of that. A couple of things in terms of budgeting. This is there are two elements to that. I mean, I think it is important to understand, who has control of the budget, and there is this. I'm looking at Chuba here that she's doing a lot of interesting work from the gender lab to try to understand, who controls the expenditures and who is responsible for what. I mean, who provides the staple foods, who provides the sauce and the different. And the different nutrients and, the sauce which contains the vegetables, the meat or the fish or the oils or whatever. One of the things that we found in several studies we've been doing, it's that also, regardless of the allocation of the resources, the expenditures vary with the different time of the year. There is also some, especially in the Sahel, there is a strong seasonality. During the time there is a time of plenty and the time of scarcity. And especially in the summer before the harvest, there is much more scarcity. So that's where the diet becomes very, very different. The last thing is about, I'm looking at Harold now, just looking at the, whenever there is a transfer of cash, there are some elements which are, a lot of people focus on trying to understand how this cash is allocated, this additional cash is allocated. And I think it's also important to understand that given the efforts that you make before you receive the cash, maybe receiving the cash changes your allocation just a little bit. It's not the allocation of the last dollar which is important, but I think it's the whole allocation which is made. So sometimes people ask questions, you received $20 and you bought shoes. Why didn't you buy food? Well, I spent all the money I had to buy food. Now I can buy shoes. And so I think this is an important element to take into account.
Thank you, Carlo. Maybe I can change hats for just a second and talk about what we do. Coming back to the question about household budgeting, and then we'll ask somebody from the field to come in. In Madagascar, actually, we are working. We have developed some games for mothers to play on payday. So every 2 months they get paid. Everybody comes together in a payment spot, and they are organized in groups already. And then they get little cards with different foods on them. And they are then encouraged to make a plan for how they want to spend the money that they will get in a couple of hours, because they have to stand in line anyway to get the money. So we're trying to take advantage of standing in line waiting for the money to come, for them to think a little bit about what do I really want to do. And they even get to take home a card. For example, if they say, okay, this time I really want to buy sweet potatoes because I've heard in the nutrition program that this is a very good food item. So they even get to take home the card. And then there's follow-up, until the next payment session to see whether they did this or not. And this came about, and this goes back to what you said, Manisha, trying to listen to them as they were getting the money. We asked them, so what are you going to do with the money? And they said, well, buy more rice. And so as we all know, that is not going to do a whole lot for nutrition. So trying to give them concrete tools and even, toys or games to kind of think about, okay, what am I going to do with the money? And, we're going to see if that works, but this is just being scaled up now. So, sorry, back. Somebody from the field, is that?
We have some comments from Mexico.
Excellent.
From Mexico.
Yes, please.
Just a sec, please. Thank you very much, Andrea. Essentially, we would like to join to this discussion that has been opened with history. I think we are obliged to learn from history of all the programs. We need to remind ourselves that 18 years ago, Mexico, Brazil, and Bangladesh started this program of conditioning transfer. Now we have almost 70 countries that have the similar approach. And we are around 2,000 million inhabitants around the world that are living and surviving through this resources transfer that is done by a condition. What we have learned in Mexico throughout all these years is that co-responsibility in terms of health and education is essential. What you can gain in several years, you can lose it in just one semester. We've been trying to push and insist that health co-responsibility should have the participation of the whole family, not only for women or the ones that are the head of the house. And they have the objective of going to these medical visits to obtain the supplement foods, and also to participate into self-care workshops. But we would like to highlight that it's very important to go through the different levels with other programs so we can break intergeneration cycles of poverty. Now in Mexico, for instance, like many other countries in Latin America and South America, we're facing the problem of the Zika virus. And that is something that needs to create an adaptation feature of all these programs. Because for Prospera in Mexico, we have 110,000 pregnant women where we have these protective mechanisms active, and also these informative and preventive mechanisms that are going to be set in place that are related to the basic sanitary measures, the cleaning procedures of the communities. So in order to inhibit that the vector that is transmitting chikungunya, yellow fever, dengue, and Zika affect importantly the health of the population that is integrated or included in Prospera program. Within the exercise that is being carried out in Nigeria, I think we have very important aspects for learning, because this resource transfer, it's what is making the change between having a dignified survivor or just being socially excluded. I think this is why it's quite prudent to say that all these condition transfer programs should have a high capacity for adaptation before all financial problems created by the appreciation of our dollar exchange among all the other currencies, the low or the reduction of the oil price, and global financial crisis that will only increase poverty. And these programs are the only buffer socially that will create stability and governability in many countries. Thank you.
Thank you very much, Daniel. And I think Mexico is really one of the examples of, where you have a very strong collaboration between the health sector and the cash transfers and the nutrition community and the education sector, of course, which we're not so much focusing on today. But it's really one of those countries where they have managed to work very closely together. The question we also as a community have to ourselves a little bit, how closely are we really working together among the health and nutrition teams and the social protection teams? How has that really worked? We'd like to invite some thoughts on these reflections and maybe looking forward. Andrea.
Yeah. So actually, I have a question which is maybe related, and I'm not so sure who to aim it at. Maybe it's Manisha, but I think others from country representatives from these projects might be able to weigh in as well. Manisha, you mentioned that one of the the key learnings is to focus on one or two nutrition messages for caregivers at a time, and that maybe flooding families with too many messages is just kind of overwhelming. But from an implementation perspective, so with a project like at the bank where we're planning basically a 5-year project, I'm kind of wondering about the evolution of that behavior change effort over that span of time. So for me, to think about creating a project around just one or two messages seems like that's I think the inclination is that that's just maybe not enough. But then you have something like the UNICEF package, where it seems like a lot of the projects that we've heard about today is maybe they're basing their behavior change on kind of existing manuals and guides, maybe like UNICEF or the ENA packages. So that has a very wide span of messages. And so when you think about versus something like Djibouti, I'm not so sure that I understood this correctly, but it sounds like maybe on a month-by-month basis, they're kind of being more responsive and choosing a particular topic to cover in any given month. And so what do we know, or what can be said about how you maybe handle planning for nutrition, behavior change messages over a span of time, and how do you kind of build that in so that it's you get your one or two key messages, you're driving that at maybe a particular time, but that you can actually plan for a large project. Anyway, I know that this is a really big question, so I'm not so sure. Take it wherever you can.
No, there's no sound here.
Sorry. Yeah, so we were just asking if there were any other questions for Manisha on the behavioral approach that she presented, and we were asking her if she could maybe write up some of those points that she mentioned. But please respond to Andrea.
Okay, so I think you raise a really good question, and it's something that we all grapple with because, if you look at nutrition interventions, and now with nutrition-sensitive interventions coming along with nutrition-specific, or the most recent Lancet showing that, it's important to look at both nutrition-sensitive and specific and look at it multisectorally. It is hard to decide, what do you do and how do you start with. So I guess my point was that not that we want to focus on one or two behaviors, but we want to start out with one or two behaviors that we know will have a high impact and that's doable, and then slowly keep introducing new behaviors over a period of time. So, for example, in Bangladesh, Alive and Thrive did start out by focusing on exclusive breastfeeding, but then they slowly moved to other behaviors, but had a very clear strategy of how they were going to address each of the behaviors and didn't just bombard it to a community all at once. So I think that's sort of the message we're trying to convey is be strategic, build on existing platforms, and, tailor the message to different audiences. Another challenge that, we've seen often is that we provide a lot of blanket messages, and I think I kind of agree. I like the Djibouti example as well, where they sort of tailor it to a specific context, because what I've seen is, often pregnant women get messages on how to introduce complementary foods to a child when the child's not even born. And that's not very useful to a mother when she's pregnant. So you want to make sure that the messages are more timely, they're age appropriate, and that they involve more than just the mother, because I think Ashley raised a good point of budgeting, and that's the case with behavior change as well, that often it's not just the woman who has control. Like in Ethiopia, we've seen that women marry young, and it's the mothers-in-law who insist that you introduce honey and water and all these other prelactals to a child. So it's not just influencing the mother, but the entire family, on better understanding who you need to target the behavior to, and making sure that the behavior change strategy is targeted to more than just the caregiver if you're trying to change that practice. So that's just our experience, and there may be others who can share on that as well.
I think Carlo had a comment. Yes, sorry. Let's, Carlo, just a second. From the field, yes? Was somebody?
Can you hear me from Djibouti?
Okay, yes, from Mali? Djibouti. Let's go first Djibouti and then Mali. Can't hear you. Zuleika? Zuleika? I think she's on mute. Then we'll go to Mali first. Bamako.
Donc, on passe la parole au Mali, à Bamako.
Ok. En fait, si je vais répondre en français, le traducteur va faire la traduction. En fait, c'est là la question essentielle de toutes ces interventions liées à la nutrition dans le cadre des filets sociaux.
So, I'm going to be speaking through an interpreter. And what we have just been discussing is the core issue in all interventions related to nutrition.
Parce qu'on a un objectif lié au transfert que nous faisons en termes de changement de comportement. Et il est important de séquencier les objectifs que nous voulons atteindre en termes de changement comportement nutritionnel aussi.
So our purpose is to create this behavior change, and it is critical that we are able to sequence the kind of impacts or changes that we want to see happen over time.
Nous, au Mali, on a 3 ans d'intervention et sur les 3 ans, on a séquencié 12 thématiques liées au changement nutritionnel.
So in Mali, we have 3 years during which our project will be implemented, and we have set as our purpose 12 themes that we intend to cover.
Donc on a 12 transferts, on aura 12 thématiques liées aussi au changement nutritionnel en termes de comportement.
So we have 12 themes that will cover various levels of behavior change through the provision of cash transfers.
On commence par l'allaitement exclusif pendant les 2 premiers trimestres et on continue avec l'alimentation de compléments. Ça, c'est pendant la première année. Donc, il y a un changement qui est souhaité sur les 2 premiers trimestres en termes d'allaitement. Et ensuite, cela, qu'est-ce qu'il faut compléter dans l'alimentation de l'enfant?
And we have, for example, as part of our themes that we are focusing on, we provide compulsory breastfeeding, exclusive breastfeeding for the 2 semesters, the 2 semesters, and after that, and we provide supplementary feeding rather, and then we want to measure the impact of that.
Et la deuxième année, on travaille tout sur depuis la phase de grossesse de la femme, les besoins nutritionnels de la femme, de l'enfant, la naissance, l'enregistrement à la naissance, toutes les questions liées à la grossesse et les besoins de vaccination de l'enfant. On le travaille pendant la deuxième année d'intervention.
So during year 2 of our project, we'll be working on pregnant women and trying to address their food needs, nutrition needs, and then we'll be working also on the child's health needs and food needs, and also their registration needs, and as well as immunization needs. Everything that is related to these will be covered.
Et à chaque niveau, on essaie de voir quelles sont les cibles qu'on devait intéresser, les femmes, les chefs de ménage. Chez nous, il y a le système des grandes-mères, c'est-à-dire que c'est des vieilles personnes qui sont dans les ménages, qui s'occupent des enfants lorsque les mères et les pères sont dans le champ pour travailler, pour faire les travaux champêtres. Donc, toutes ces cibles-là sont mobilisées et en fonction de chaque cible, on essaie de développer des communications spécifiques à l'endroit de ces cibles-là.
So we have also developed and identified the targets, the target groups within the communities, within women, for example, heads of families, and we have what we call here these old and wise women who are old age women who remain with children and take care of children at home while the mother and the father are away working in their farm. So we are developing tools and ways to monitor this and to develop this.
Donc voilà un peu ce que nous faisons au niveau du Mali. Je pense bien que ça permet de pouvoir résoudre ces besoins-là en même temps.
So we believe in Mali that by focusing our efforts on these areas, we can move nutrition and our intervention forward.
Thank you very much. Very interesting on the sequencing. Djibouti, was there? Did you?
Yes. I don't know if you were able to hear me the last. I think my internet went off and it came back again, luckily. Yeah, it was just to address the question that was asked by my colleague over there about the different messages that we have got. Because it's, as I think the lady said, it's difficult to sort of maybe maintain one or two messages because, for instance, our program for a child who's up to the age of 2, if the mother came, just as she had the child, she would have 24 months of sessions to attend, and that's why we try to very much vary it each time if possible. But also, in terms of the behavior change, although our sessions are very much nutrition focused, we also try to resolve problems. For instance, if it was a time when a beneficiary has been referred to a local health center and they were actually out of stock for the supplements that the child would need, so she came back with a referral, and within that day they were discussing what to now do since there is a shortage of supplements within this health center. Is there a way we can maybe go to the other neighboring health center to have the supplements? And it was sort of try to see how that can be done. And some of our mères conseillères do have relationships with those health centers and work with maybe who would be best to take them along to that health center. So that's the also sort of problem resolving, problem resolution that we try to find as well within our sessions. And it's very important to remember the importance of culture and religion within our communities. One challenge we had particularly was in the Djiboutian culture. Once a woman gives birth, she shouldn't get out of the house for the first 40 days. And it was very difficult to do the postnatal care since we have this culture of not going out of the house and, something would happen to the child and it's dangerous. And so it was interesting because the health center, once the woman gives birth and goes home, they say to her, you have to come to your postnatal care 7 days after you gave birth. But they weren't very much insisting on that because they knew it was a culture. Our norm was for her to stay at home for the 40 days. So once we started the social safety net program and the message that we were giving to them is to have the postnatal care within 7 days after giving birth, we really had to work not only with the beneficiaries but also with the health center so that they can reinforce this message, even though it's the social norm that they don't go out until the 40th day. And I believe it's really worked, as we've got an indicator for that, and we can see that there's been an improvement, an increase in the number of the women who attended the health center within the 1st to the 7th day after delivery. So not just nutrition-focused behavior change, but also trying to find solutions to the problems that we've got at that particular time as well. Thank you.
Thank you very much. I think we have a number of questions from people listening to us and from the field. So, Aaron, can you give us a taste of what came in?
Sure, absolutely. So thank you for everybody that's been active. We've got about 9 questions so far and can't hit them all, I don't think, but there are a few that kind of continue on this train of thought around behavior change, nutrition education, and messaging, and I think we can find sort of a common thread and maybe tie it to some of the tools we've been hearing about as well from Djibouti, for example, just talking about the boîte d'image, and from Mexico in the Prospera presentation, a number of materials were also shown, because several of the questions hit on the theme of what indicators essentially are in place over time to measure that those behaviors and those messages are being taken up in an impactful way, that we're actually seeing sort of ownership of the messages, of different types of problem-solving behaviors developing, of different practices developing, etc. So I thought maybe it would be possible to sort of link these things together and ask a question around for the nutrition materials that are being used in the context of these social education projects, what indicators are in place to measure their usage over time, and not just the transmission of knowledge, but the achievement of different behaviors and even transmission of those behaviors inside the household itself?
We're giving that question to Manisha, since you brought it up.
Yeah, so I kind of agree that it's really critical to understand, what indicators to use and how do we even assess whether the materials are effective or not. So from our experience, it's shown that it's very important to measure the exposure to coverage. So, for example, how frequently, it's been shown that interpersonal communication or one-on-one communication is very effective for behavior change. So one way to measure whether the materials are working or, whether behavior change is happening, we'll talk about that a little later, is, but to start out, it would be very helpful to look at the exposure variables, so what is the volume of contact, how frequently are the target population in contact with, the mayor, conseiller, or just whoever is providing nutrition education, whether it's a health worker or a volunteer. So it's important to measure that. It's important to measure what proportion are getting covered by the message. So, for example, I think we saw in the case of Niger and Djibouti, it's pretty high. So a lot of the social protection clients are attending these sessions, so it's important to address the volume of that. With regards to measuring behavior change, it's a little difficult to measure that through a monitoring system, and what many programs do is either set up like a sentinel surveillance where you can measure changes in practices every 3 months, or you have to conduct a regular household survey where you look at changes in practice over a period after a certain amount of time has lapsed with exposure and volume of services provided. But I do think it's very critical to constantly measure that, to understand, who your audience is, how are they being reached, and whether they understand the messages that are being targeted to them.
And I think, thinking maybe on the way forward for all of us, this would be a good topic to group around, to think, what are the things that we can actually measure in terms of behaviors. Right. So that's a common theme, I think, among the nutrition community, also with the social protection community. So that could be a good common ground for further work. We're coming almost to the end of the session. It's 1:10. I think we need to, almost close. But our last question is really, are there any thoughts from your side of the way ahead? Clearly there is a common ground among social protection and health nutrition colleagues, and common questions, but we're still also all of us caught in our own little worlds. So are there any, besides kind of thinking about maybe common indicators so that we could measure, are there any thoughts of how we could move this agenda forward together?
I don't know if I can add just one or couple of inputs from Djibouti again, please. Yeah, it's just to add a little bit on what my colleague has said. It's just that what we do in Djibouti it's difficult to follow whether the behavior change message has been fully taken on board. But what we do particularly, and maybe something we might all discuss, is we do regular supervision. So we ourselves go over to the site where the nutrition session is being carried out, and we ourselves talk to the beneficiaries and ask them questions there and then. So the message today is, for example, exclusive breastfeeding. How many of you are actually doing that? What do you think of that? Again, going back to our culture is, if you give too much breast milk to the child, then you won't be as attractive to your husband. Sort of discuss these cultural issues that we've got within our community and see how the message that is given can be complemented within our culture. And something else we do is our mère conseillère. What's good with us is that they act with local women. So it's very much women who live in that locality, and that's very, very helpful for us to follow if the message that was given in the session has been carried on and taken home. And what they do is they do home visits after the sessions and see women if they're actually, for example, the cooking sessions, if women say, oh yeah, I'll do that in, tomorrow night or something, she'll do a home visit and say, how are you getting on with that? Would you like me to, help you with the ingredients and see if they're actually doing it? And sometimes they divide themselves into groups and go to different households. So that's two ways for us to see if the message has been taken on, and if you've got more to suggest, then we'll be very happy to take it. Thank you.
Thank you. So that basically much more communication at the local level among program implementers and the nutrition and health workers, basically. That I know that Carlo needs to leave, but I think you also had some comments on this still.
Yeah, very quickly. I just wanted to reiterate the fact that how the different elements are introduced is important. For example, in Niger they start with the hand washing. So the first set of things, it's on which you build on, and then you introduce carefully one element after the other, and how this element is linked with the other elements, and the timeline which is implemented is also important. Like Mali is talking about implementing over 3 years' time. In Niger, we're talking about 18 months' time, and that changes from the context to context in which you have. But there is a time limit. In terms of monitoring, I think what I hear is also what we do a lot of Niger. It's based on the kind of supervision and structure that is in each one of these programs. So if you have you have the local health worker, and then you have the supervisor and the supervisor of the supervisors. What we're trying to build is an active. What we try to do in Niger is an active monthly basis reporting that it's fed directly into the MIS systems in terms of the participations, the number of things which are done, and then there are frequent visits which are done by the supervisors which check on and some of them are pretty funny too. I can testify to that. Are you really breastfeeding? Yes, I am. No, I'm not. Are you washing your hands?
Very good. Okay, I think Amadeus wanted to come in, and we're almost then ready to close. But Amadeus, come on and yes, please.
Thank you. I just wanted to cite a need to take results from impact evaluations and inform the institutional frame, because you see this topic is not handled by only one sector. Just like I was mentioning here in Tanzania, we have a forum at the national level which is involving different sectors, NGOs, local NGOs, international NGOs. So the results that we get from impact evaluation being indicators which could be very good to track change in behavior, if that could be fed into the framework which is involving different sectors, so that we should not reinvent the wheel in different sectors where we are working. That could help a lot, because we have a number of players in this area. But I wanted also, there was somebody who was interested in household budgeting. We have tracked this. We have done an impact evaluation in Tanzania, and the report is online. Probably, Andrea, you can share with her my email address. I can link that person with, so that she can see what you've been able to track on household budgeting. Thank you so much.
Thank you. Yes, and that's actually also, I think, Amadeus, a very good suggestion to start sharing, possibly, through this forum, some of the documents that we have, some of the insights, some of the evaluation results. And because I think a question of the organizers is also where do we go from here? Is this clearly we're all starting, and many of these programs are starting out now, bring in some experiences, bring in some data also. So this is a good moment probably to, move this agenda forward more in a more organized way. So I will just put that out there for the organizers, please, to guide us on how we can continue this conversation and the exchange of experience also. Manisha, any final thoughts from your side?
Well, maybe just to kind of re-emphasize that in order to design a good behavior change strategy or an intervention, it's really important to understand our audience and who we're working with, what their current behavior looks like, and what is likely to stimulate or retard behavior change, and then to really find effective ways to reach the audience. I think it's very, very critical to look at this while we design behavior change strategies, particularly for social protection programs. Thanks.
That's right, and that's the very hard part. Very good. So we've heard today from a variety of programs, very different approaches, some more on the nutrition education, others more thinking about behavioral changes directly and trying to incentivize those behavioral changes. Some programs very complex and very large, and others fairly small and just starting out and focusing more on the local level. I also find it striking that in some countries there seem to be strong education and health health and nutrition programs, and so there's more collaborative approach. In others, apparently, the social protection programs are really taking over some of what normally nutrition programs would be doing. So that, like in Niger, it seems that there wasn't much in terms of other nutrition programs out there. So that also brings us into a position where it's not that easy to choose and where we even have to work together more closely, it seems. So I think as results are slowly coming out from evaluations, it would really be important to share those. And we are looking forward to Carlo and his team from Niger, I think, as a next step to present to us the findings that you have. But please, everybody who's listening and who's here in Washington, share your experiences, share the documents that you have. I think Aaron is in charge of organizing us. Is that correct? And Leslie, of course, Leslie Elder. And so I hand over to you, basically, to help us organize ourselves and work more together. Leslie, do you have any final comment, maybe, please?
No, we need to close. I know we're beyond time, but just thank you, Andrea and Manisha, and all of the presentations and the panels. We can't thank you enough. And exactly as Andrea has pointed out, we will make sure that the results of our discussions here today, and we'll send around a summary, and we'll keep in touch through SecureNutrition as a platform where we can talk together and continue the collaboration. Thank you.
Excellent. With that, thank you very much to the presenters, first of all, to our external guest, Manisha, and to everybody who came here today and to listened in globally. Thanks very much. Have a very good day, or have a good afternoon and evening. Bye-bye.
Thank you. Thank you.
Thank you. Thank you very much.